So my topic for the day is once trabeculectomy is done, how to manage now. So most of the times what happens is, many of the general ophthalmologists are now developing more confidence and they are performing trabeculectomies themselves. So once it is done, trab is relatively very simple. I mean, I used to be scared of trab, and Dr. KP sir was the one. He said, "Arey, ye kya hai?" And just two surgeries down the line, I was actually very confident of managing the trab. But the post-operative management is what is most important. See, what happens is we are trying to go against the mighty nature. We are trying to create holes where there are supposed to be none. So expect the body to react. It is going to try and close the sclerostomy. So how do you proceed with the management of a failed bleb? Recognize the failure. You should understand, once you look at the case, you should understand that the bleb is failing. There are various grading scales. There are various methods by which you can assess the bleb morphology. They are mentioned. I won't go into the details of these. OCT-based assessment is currently the best way to understand and identify the early bleb failure. But if you don't have the OCT, you don't have the advantage of having an OCT which can view the anterior segment. Simple clinical techniques can help you in diagnosing the early failure. So if favorable bleb is something which looks like this, it should have microcysts. There should be paucity of vessels, diffuse drainage, and a moderate elevation. Whereas unfavorable bleb is, it's angry looking. It is avascular, or it may be too much avascular. It might appear blanched out. It might be flat or very elevated with a smooth or dome-shaped appearance. It can be a well circumscribed bleb, which, indicating that there is an encystment formation. There will be a surrounding fibrotic vascular link, and there will be a lot of microcysts. So once you apply pressure over the eyes, there is no fluctuation you notice in the bleb. So risk factors of a failing bleb, we have all studied during our post-graduation times. I don't need to go over this, but anyone who is young, males, the black race, of course, we won't come across that over in India, but congenital and juvenile glaucoma, subconjunctival hemorrhage, excessive hemorrhages, excessive inflammation, these all can lead to an early failure. But the main risk factor will always remain the surgeon. There are two hindrances. The surgeon first is मैंने तो trap कर दिया है and it's going to be successful. This is denial. And the second is the ego of the surgeon. कि नहीं, मेरा trap तो fail हो ही नहीं सकता है. Once you get over these two factors, that is when you will understand. And a good surgeon is not the one who identifies the damage, but does damage control. So you should identify the cause. You should get into the detailed history of the patient, the surgery, and the post-operative period to understand. There are two main causes. There are pathological agents working against the trap, and there are physical agents. So pathological agents, let's go back to our second year MBBS and try and understand. The wound healing post-trabeculectomy surgery, it's coagulative phase. Then there is the inflammatory phase, the proliferative, and then the remodeling phase. So each stage, once you target it properly, it can help you out, in managing and saving the bleb. So the inflammatory phase, you have a lot of patent aggregation and other blah, blah, blah. I'm not going to go into this detail, but a careful perilimbal conjunctival dissection or an incision with a careful handling of the Tinon's capsule can help in reducing the inflammation that can be elicited by the body and by the eye of the patient. You should not be very haphazard. You should not butcher up the conjunctiva. The proliferative phase is where the angiogenesis and the fibroplasia happens. It usually happens from 1 to 3 weeks. And intraoperative use of mitomycin C with 5-fluorouracil in the postoperative period can help you in saving the bleb. 5-fluorouracil is something which we are all afraid of using, but trust me, it works really well. You just have to give, 180 degrees or 90 degrees apart. You have to give it subconjunctivally with a lot of lubrication in the post-operative period. 1 or 2 injections, OD or BD for 5 days, or you can be OD alternate day for 5 to 6 sittings. And it really helps out in the long run. Future prospects. So there are a lot many what you can say chemicals, molecules coming into pictures, which may help in saving the bleb in an earlier phase. 5-fluorouracil can be used in adjunctive as an adjunctive to these factors, but due to their cost constraints and the availability, they are not currently widely used. But yeah, I'm looking forward to these agents. Then the maturation phase is when there is a shift in the collagen, which happens from 4 to 6 weeks. And bleb needling or revision is the only thing that can actually save the bleb. So the courtesy for this video goes to Dr. KP sir. Bleb needling is a very simple technique, usually done under topical anesthesia in cases where the patients are cooperative. All you need to do is, my video is clear, right, Dr. Karan? I mean, it's playing well.
Yes,
Yeah.
it is.
So you just go with a 30G needle. You inject a little bit of lignocaine in the subconjunctival space. Then you bend the needle and at least 6 to 7 mm away from the limbus. Go there with the needle, the sharp edge. You start breaking the adhesions, the fibrosis. Preferably, it should. If you have done the trap yourself, you would know where the flap is going to be, and you go near the flap, trying to break the adhesions and raise it slightly. Some surgeons, they become a little overzealous and they go into the anterior chamber. It depends upon the number of weeks that have passed and the amount of failure. Bleb needling, if done properly, once or twice. No, I would suggest only once with 5-fluorouracil in the post needling phase can work really well. Now, the physical causes can be blockade of the internal ostium or the external ostium. Internal ostium, if there is a blood, you can simply use plasminogen activators. If there is the iris, which is iris and vitreous blocking the internal ostium, in those cases, you can simply use a YAG cap. Not YAG cam, I'm sorry, YAG laser to disrupt. In case of a vitreous, energy will be required will be lesser. In case of iris, the energy would be higher. Preferably, our argon laser would be a better in cases of iris. Rather than breaking it up, you should make it contract. An internal bleb revelation is sometimes required, but you need a direct gonioscope for this. Obstruction at the external ostium is a scleral flap. This is commonly the most, it is the most common cause, a tight or excessive sutures. There is a role for bleb massage, laser suturolysis, releasable sutures, or adjustable sutures. But bleb massage, suture, laser suturolysis, these are little complicated and ungraded methods. So I would suggest that everyone should learn how to put a releasable or adjustable sutures. Again, the credit goes to Dr. KP sir. I was able to record this video with his help. There are many types of releasable adjustable sutures. There are many modifications which are available over the internet, but this is the one which I have been following. And this is, you have a distal end and the proximal end, there is a loop. So you can simply use a earbud over the transconjunctivally. You can just kind of, nudge it so that it can become loosened out. And what I am doing right now is the distal end, I keep it subconjunctivally over here, and it protrudes out in the post-operative phase. So if I'm unable to loosen it up with an earbud, I just simply pull onto it, and the suture comes off. Now, once you have done the release, the next thing is to restore the bleb function. Forming the bleb is very important. Now, there are various techniques. You can simply press onto the upper lid, or you can press onto the lower lid. It can be done by you every day, or the patient can be taught himself or herself to do it at home. I usually do it once or twice in my clinic on the first day when I have done the needling and the other things. And after that, I usually train the patient to do it himself or herself. I just tell them, even if it, your vision decreases or if there is too much of egress of the aqueous, you can just simply close your eyes and lie down for 2 hours, and the vision will be restored. So take home message is, failures are part of the game. Glaucoma is essentially a surgical disease. So train yourself to handle it. Take guidance and help from experts and perform a meticulous surgery. Always have a plan B. Use of drainage devices or referral of the case to your senior in time can really save the patient's eye. Glaucoma, there are two schools of thoughts, where one school, people say that it has to be managed with topical medication for as long as possible. And then there is another school of thought where people say you should operate once there is a 0.6 or 0.7 cupping and the IOP is 24 with maximum medication. So I'm a little more aggressive. I tend to operate these cases, save the eye while you can. So thank you.